Welcome to our spring 2021 Race to Erase MS Forum. I'm Claudia Curry-Hill, your moderator for today's panel. We will be speaking today on the future of MS treatment and about COVID, vaccines, and MS. Some of you have sent in questions and they will be answered after the presentation of topics. When I was diagnosed with MS in the early 1980s, the disease took years to diagnose and there were no therapies proven to slow its course. Things have changed thanks to the doctors and researchers sitting on this panel and the philanthropy and activism of people living with MS like Nancy Davis, founder and president of the Race to Erase MS. It is my pleasure to introduce our panel today. Dr. Margaret Burnett from USC, Dr. David Hafler, Yale, Dr. Adam Kaplan, recently transitioned from Johns Hopkins to Chief Scientific Officer of MyMD Pharmaceuticals, Dr. Ellen Mallory, Johns Hopkins, Dr. Nancy Sykott, Cedars-Sinai, Dr. Rhonda Boskel, UCLA, Dr. Emmanuel Wabant, UCSF, Dr. Howard Weiner, Harvard, Dr. Vijay Yadav, Oregon Health Sciences, David Osman.
I got the link, I'm on.
Good.
Good, I just said your name. Dr. David Osman, not Dr. Osman. David
Well,
Osman.
we can just stick with tradition. Dr. Osmond's fine with me.
Entertainer,
If you say so.
motivational speaker, and MS advocate, and Nancy Davis, founder of the Race to Erase MS. I hope you have downloaded and read the Center Without Walls biographies of all these amazing panelists. Our topic today is the future of MS treatment. But first, I would like to introduce Nancy Davis to talk to you about Race to Erase MS. Nancy?
Thank you so much, Claudia. Last night we had our 28th annual Race to Erase MS. It was a real live event in Los Angeles at the Rose Bowl. We had Earth, Wind, and Fire performing, and it was opened by the amazing David Osman with his new band. So David, thank you. He looked so incredible. He was so handsome. He sang so beautifully. He's just amazing. And some people from this amazing band also accompanying him. So it was a pretty awesome night. Earth, Wind, and Fire, I still feel like we're in Boogie Wonderland. And it was just an amazing evening. I think everybody's really getting excited that we're getting out of COVID. I think everybody during this pandemic has been having, a lot of anxiety and not knowing where we stand, and people with MS feel their immune systems are highly challenged and there's a lot of, questions to be answered. We're so fortunate that, a lot of research completely shut down during the pandemic. We're lucky to have the most generous supporters, and we were able to do an event last year and support a lot of research. We are grateful that we're able to do that. Last night we had a great event, and we want to keep being able to fund the 8 doctors in our Center Without Walls with this really important research. It's our passion. It's what we want to be able to do forever, and we're forever grateful. I have MS. I have had it for 29 years. I'm probably the luckiest person living with MS. I'm doing really, really well. I know that's not the same case with everybody. I know I'm so fortunate. Lucky that when I was first diagnosed, I went to some of these great centers that you're watching here with the most stellar doctors in the entire country, actually in the entire world. They have come together to work as this dream team of doctors, and they put down the traditional barriers that exist in research, any kind of medical research, but especially I congratulate them for being what they are. And you will hear from them today. They have amazing stories to tell you in this past year. Even though there was a pandemic, they have been working really hard, coming up with great new novel concepts to help people live with them. I'm so grateful to know them, to be in their presence, to be able to help them. And all the monies that we raise from Race to Erase MS, we have these beautiful fun nights, which everybody so generously donated to. But the big pictures, this is what it is all about. This is the Nerve Center. We are constantly striving to do different things, better things, more things. And our goal is we are a race. We want to cross that finish line. We want to find a cure for MS. And we're always all open to any new, greater, better ideas. So thanks everybody for tuning in today. Congratulations to this esteemed, brilliant panel of doctors. I'm so honored to just be in your presence. I'm thrilled every time I hear from you, talk to you, know what you're doing. I see on a daily basis the lives that are changed by everything you have done and continue to do. I think this has been a really harder time in the world and people don't know what to do. I think there's lots of big questions on COVID, and as we go forward, will there bring more types of COVID? There'll be other versions of pandemics and different things, and how do we protect ourselves as patients living with MS, and what should we be doing? Looking at Dr. Kaplan, I think there's been a really big problem with mental health this year, and I think it's really important that we address that and we empower everybody to deal with that. So there's so many different aspects of each person here does something different with MS. Nobody's duplicating research. That's the idea of this whole group, never to duplicate, but to constantly communicate on all versions of research. And sorry if you see my husband in the back, but what can I say? Excuse me. And what can I tell you? We're so grateful. So everybody, thank you for being on this panel today. Thank you to the doctors. Thank you for everybody. Thank you for everybody that supported us last night. We had a really fun event. Thank you to Liz Sears, who's just the most amazing human being on the planet, for helping chair and organize our event, and everybody who came last night, everybody who supports us. And thank you, Claudia.
Thank you, Nancy. So the first on our topic to speak will be Dr. Emmanuelle Wabant, and she'll be speaking to us about COVID, vaccines, and MS. Emmanuelle.
Yeah, good morning, everybody. So I'll just briefly introduce myself, since we did not do a round of introductions. I am a professor of neurology at UCSF in San Francisco, and I do clinical research, and I also take care of patients with pediatric MS. So the topic to cover on my end is COVID and vaccines and MS. And a year ago, we were really in a very stressful situation when the pandemic started to spread, and there was a lot of unknown about how COVID and MS would do. And now there's been several studies that have shown that having MS in itself is not actually a risk factor to develop COVID infection. And patients with MS have the same type of risk factors for severe infection, which include having comorbidities such as cardiovascular comorbidities or kidney disease or obesity. There are additional risk factors that seem to be making the risk of being admitted in the hospital higher, and these include being a male, being Hispanic or African American, and then probably having advanced disability also increase the risk of being admitted in the hospital. Through lots of kind of weekly discussions with international people that I spearheaded, but several MS societies also spearheaded, we have been able to share in real time what was happening and understand whether specific treatments for MS were increasing the risk of a severe infection. And what has panned out in 2 or 3 studies is that probably medications like rituximab or Ocrevus may increase the risk of admission in the hospital. And we basically really kept an eye on that to make recommendations to our patients. It didn't look like other treatments were increasing that risk. But again, it's very difficult to really be sure of these issues, just because there's lots of other things that could increase the risk or decrease the risk. So now we have the vaccines on board, and it's been very exciting to know that there was some light at the end of this long tunnel in the past year. And initially there was some concerns from patients, more than doctors, I have to say, about whether these vaccines would be safe for patients who have MS. And the clinical trials that have tested the vaccines have usually tended to test people who were in good health overall. But because of the follow-up in these studies, there was really no strong argument to think that there was a risk for patients who had autoimmune disease, such as multiple sclerosis. And from the theoretical standpoint, we know what these vaccines induce in terms of immune response. There was also no real reason to think that they could make MS worse. Now we are several months after people started to be vaccinated. So we have, at least 5 full months of vaccination on board. And so far, we have not seen an increased risk for patients who have MS to have MS flares, for example. But I will say that there's 2 caveats. One is that for patients who have advanced disability, if they develop, for example, a little bit of fever after the vaccine, they have tended to actually feel weaker for a day or 2 after the vaccine. And I advise some of my patients who were walking with a walker or a cane, or patients who were in a wheelchair, to actually take Tylenol systematically after the vaccine to try to control a little bit better these pseudo exacerbations. So this was not at all an exacerbation of MS. It was what we call pseudo exacerbation that happens when there's heat or fever or exposure to sun. And so all the patients I know who may have experienced a little bit of a bump on the road after one of the injections of the vaccines, within hours or days were much better. And the last thing I will say is that now and I'm sure there will be a lot of questions about that. With the vaccine, there's lots of questions from our patients whether, depending on the medications for MS they are on, whether they'll be able to mount a strong response to the vaccine. And at this point, we recommend that patients with MS be vaccinated, because we don't think there's any dangers to be vaccinated. On the contrary, it will protect them from an infection with COVID that can really be setting you back big time. And there are questions whether medications such as Gilenya or this family of medications, siponimod, ozanimod, the S1P receptor modulators, and the medication that target B cells, also like Ocrevus, rituximab, or Kesimpta, may actually decrease the response to the vaccine. So there are theoretical reasons why we think they may, but there's really no data to suggest that the vaccines won't protect patients on these medications. So there are several studies, and several of the people on the call today are contributing to those studies to try to understand what is the immune response to the vaccines in patients on various disease modifying treatment for MS. I'll stop there.
Thank you. What's on the horizon? New MS therapies to advance MS treatment. Dr. Howard Weiner, can you tell us a little bit about this?
Claudia, thank you very much. Nancy, hi to you, and thank you for all your efforts. Hello to everybody from the Center Without Walls. It's very great to see you. Nancy, you helped me out with my granddaughter, so I want to thank you. You referred somebody at Cedars, so that worked out very well. Thank you very much.
Thank you.
David, it's always nice to see you, David. You're as handsome as ever. So
I have an ophthalmologist for you.
So anyway, one of the major things that we're trying to do, one of the major areas is progressive MS, and with support from the Nancy Davis Center, we're working on different aspects of progressive MS. I'll mention 2 things. One is the microbiome, which is the gut. And one of the junior investigators from the Nancy Davis Center, Lori Cox, who's a wonderful young microbiologist, and she's studying the microbiome in our MS patients and looking for different types of special bacteria that we might give to MS patients. So we're hoping that could be ultimately a treatment. Another thing that we've been working on that we're very excited about is something called a nasal spray, a nasal vaccine for MS, where we've discovered in animal models, if you give a monoclonal antibody nasally, it helps the progressive form of MS. So we've been working on this. And actually in May, we treated our first patient in a clinical trial, someone who has progressive MS who hasn't responded to some of the new therapies. So he's getting the treatment. Everybody knows how hard it is to move something from the lab into clinic and how clinical trials don't always work out. But as you say, is if you don't try, you never are going to succeed. And one of the things that is part of the Nancy Davis Center, and Nancy always wants, is to try new things and not to be afraid. So we're not afraid to try. And what I can tell people is that we have new treatments on the horizon. Every center is working on new treatments. At our center, we're working on the microbiome and we're working on this new nasal spray. So we're very excited. I would say that Dr. Waban also has been very involved in the microbiome and headed a beautiful seminar with Henry McFarland on the microbiome where we discussed it with scientists from around the world. So that's what I have to say. It's great to see everybody and I'm very excited to work with everybody and thankful for Nancy's support.
Thank you.
Thank you, Dr. Weiner. Next, is use of mRNA vaccine strategies for MS and other future immune therapies. Dr. David Hafler.
Thank you, Claudia. And again, thank you, Nancy, for all that you're doing. And some of you may know that Howard's my scientific father, so always great to see him and everyone else. So it was an interesting question. We had a little discussion before. There was a recent paper that had some degree of publicity using mRNA. So first, to step back, what is mRNA? So as you may recall from your high school biology, DNA is a genetic code. And what happens is DNA is made into message mRNA, which then gets translated to proteins. And this is, of course, fundamental for the COVID vaccines that are being used. I'll address that in a moment. So the question is, is there a way of turning off MS or vaccinating against the disease? As I pointed out in a question that was asked, the technology to develop vaccines against microbes goes back to 1796 and Edward Jenner, who developed the technology to do this. So nothing has fundamentally changed since the 1790s in terms of vaccines. We know a lot about it and how to make it work for microbes. It's very different where rather than trying to induce an immune response, we're trying to stop an immune response, which is what we're trying to do with multiple sclerosis. So in that particular paper that many were referring to, the scientists took mRNA against a protein known in animal models to induce a model of MS, an experimental autoimmune encephalomyelitis. To my mind, the paper was fundamentally flawed as related to human disease, in that the treatment was a self-fulfilling prophecy. They knew what induced the disease in their model, and they blocked the response to that protein in their model using mRNA vaccine. And of course it worked. We've known that for 40 years, that if you block T cell responses to an antigen that induces a model of MS. In fact, Howard and I worked on this using oral tolerance back in the 1980s, 1990s, trying to do antigen-specific therapies. So the fundamental question which emerges from that is, if MS is an autoimmune disease where T cells are attacking the brain, what is the antigen? What is it that the T cells are attacking in the myelin? And the answer is we really don't know. We just know that there are animal models that you can take myelin proteins and do something that looks like MS. So in order to try to address this without bias, the grant we submitted just a few weeks ago to the Race to Erase MS is to use a very new technology to answer that question. And what we're doing is we're taking expanded T cells, immune cells, from the spinal fluid, from the nervous system patients with MS, without any bias, screening those T cell receptors, these T cells, with a very new technology against all myelin antigens to see if we can finally figure out what it is that's really inducing MS. And if we could do that, then we may be able to specifically target that by message or other means. So I think that paper was overhyped and a lot of false hope. We've been trying to develop antigen-specific treatments for autoimmune diseases for decades, and so far we've not succeeded. Let me throw out one other idea for mRNA vaccine, which I think is actually really exciting that's going to happen. And that is a vaccine against EBV, Epstein-Barr virus. We know that 100% of MS patients have been infected with EBV, but about 90-odd% of control subjects also have had EBV infection. We're all intrigued by the fact that if you deplete B cells in relapsing-remitting MS, it works so well. So a fundamental question is whether or not EBV, which infects B cells, is sort of the adjuvant, that the danger signal that is actually causing MS. So the only real way of answering that question is to perform a vaccination, perhaps using mRNA vaccines with EBV in individuals and children at risk for developing MS, to see if it prevents the disease. So to me, that's one of the most exciting potential new therapies. The other things that we're all doing is trying to go early and early in the treatment of disease. That is, every study has shown that the earlier you treat the disease, the better the outcome. So the approaches that many of us are using now is to try to treat very early MS, radiologically isolated syndrome, or even a new syndrome, which we've labeled, have no evidence for, we're calling immunologically isolated syndrome, which is even before there is damage to the brain, to identify the events when there's inflammation, autoimmunity, but before the brain gets attacked. And I think if we could stop the disease then, we'd be able to get as close to cure as possible. So this, along with the wonderful therapies that Dr. Weiner is trying with nasal tolerance, anti-CD3, and progressive, a number of new therapies on the horizon. But my God, as Nancy says, how far we've gone from the time I joined Howard's lab in 1981. So I'll stop there and we'll have time for more questions.
Thank you, Dr. Hafler. And next, vitamin D, antioxidants, and gut microbiome, Dr. Ellen Mowry.
Thanks so much. I'm really happy to be here today. So I'll give as brief an update as I can on three pretty complicated topics. Vitamin D, of course, has been of interest for quite some time for people with multiple sclerosis, and early studies suggested that lower levels of vitamin D might predispose people to developing multiple sclerosis. Some of these data were challenged in a more recent paper, which demonstrated that that was not universal amongst all people, and in particular, people who identify as Black or African American or Hispanic Latinx. Vitamin D levels may not be associated with increased risk of MS, whereas sunlight exposure, which is associated, of course, with vitamin D levels, but has independent effects on functioning, still remained as associated with MS risks. So a bit complicated. There have also been some new data looking at the MS prodrome. So a sense that for years prior to developing the first definitive symptom of multiple sclerosis, that people with MS start to feel different. They start to seek more medical care. And so I think it's important, both from the vitamin D story, as well as for examining other risk factors that relate to behavior, to make sure we're not assessing those factors or behaviors within a period of time of the MS prodrome, where subtle changes in health may, for example, lead people to stop going out in the sun because maybe it doesn't make them feel good. They're already sort of on the pathway to developing MS. And then it can appear like the thing you're measuring, in this case, low vitamin D, is an MS risk factor. Nonetheless, we and others have shown that low levels of vitamin D in people with MS are associated with higher degrees of relapse activity, as well as higher degrees of developing new MS spots on the MRI scan. Clinical trials to date of vitamin D supplementation have been done in Europe as add-on to older versions of MS medications called interferons, and were not successful. Important to note that they use pretty high doses of vitamin D, well above what would be physiologic. Our own trial is done and we're currently analyzing the results. So we hope to see if a more moderate dose of vitamin D is useful. Interestingly, in work that we had funded by Nancy Davis, we looked at vitamin D supplementation in people with MS and healthy controls, and we actually saw that it had different effects on metabolism and particularly on antioxidants. So speaking about antioxidants in healthy individuals and those with MS. So specifically in individuals who are healthy, higher levels or higher supplementation with vitamin D actually led to improvements in oxidative stress markers, whereas that was attenuated in people with MS. And so there may be a lot of complex things going on related to vitamin D that has downstream impacts that are different for people with MS. The topic of antioxidants is pretty broad and complex. So our bodies are always generating these sort of toxins, right, as byproducts of metabolism called reactive oxygen species. And these are elevated within MS lesions or spots in the central nervous system. And so there's always been a long interest in understanding whether dietary antioxidants, so things that sort of combat these reactive oxygen species, could be useful for people with MS. It's been really hard to study these, I think, because we consume these foods that contain antioxidants in aggregate. And so it's hard to sort of piece apart one versus the other and measure it and then be sure that what you're measuring is related is truly important. We definitely know that, delivering antioxidants in a mouse model of MS called EAE seems to be helpful, but whether or not, individuals or just sort of the whole diet that leads to a higher level of antioxidants is useful for people with MS is not really well known. And in fact, it's pretty challenging to do these dietary trials, which don't often receive a lot of funding from traditional funding sources, which is why organizations such as that of Nancy are so helpful to getting these kinds of studies off the ground. And finally, gut microbiome is, you've already heard, a hugely rich area of active research. You're looking at two of the giants, Dr. Vauban and Dr. Weiner, who are doing a lot of this work. Some really interesting work from both labs looking at specific microbiota and how they relate to potential risk of relapse or disease activity, risk of disability over time, looking at intervening upon the microbiome through fecal microbiota transplant. I think we're all looking forward to seeing more of those data. I know that we're at our center looking at the downstream effects of the microbial activity through measuring in the blood components of metabolites that come from the gut microbiome. For example, one of Nancy's junior investigators, Pavan Bhargava, who was funded in a project, found that people with MS, particularly those who are more disabled, had low levels of bile acids and was able to get funding for a clinical trial of bile acid supplementation. So I think I'll stop there. Happy to take any questions.
Thank you, Dr. Mallory. I appreciate that. We will be getting to questions in our lightning round after everyone has spoken. So if you have any questions, be sure and get those in. Next on the agenda is diversity and MS, Dr. Margaret Burnett.
I am glad that you could come. It's good to see colleagues as well. So one of the things we've focused on at USC, along with my colleague, Dr. Amezcua, has been the differences in Hispanics and African Americans as far as their course of multiple sclerosis goes. There are several complicated wrinkles in the situation in that patients with Hispanic background, how do you define them? How do you define African Americans? So one of the early studies that was done in conjunction with UCSF was looking at the mixture of genes for different populations in different parts of this country, for instance. And it's clear that European genes do affect the risk for African Americans, for instance, and that Hispanics have both some Asian genes and some Central American genes that may affect their risk. But we know that MS is due to both genetics and environment. And so we have to ask, are there other aspects of the patient's lives that have affected their course? One of the things that has been noted in several studies, including one of our own, is that for instance, Hispanics tend to have optic neuritis as a presentation or transverse myelitis, a spinal cord lesion. And the problem with that, and it's also seen in African Americans. And the problem with that is that then these patients become disabled earlier. So, it's very important to think of what we can do and how aggressive we should be, what treatments we can use. There have been studies where they've looked for different factors and matched patients and, for instance, Caucasians and Hispanic Americans, and looked to see what the possible differences could be. They match for age and gender, education, etc. And really there are some factors intrinsic to these patients that seem to modify their risk. Of course, we also have to worry about whether there are societal factors, whether patients without insurance have access to care, and whether they're getting the same treatments, they have access to the same treatments, what their lifestyle means, as far as, for instance, what effect their lifestyle has on their microbiome, for instance. So there's a number of different aspects of lifestyle that may make a difference. And of course, we're working to make sure that the county system, so I'm privileged to work both at USC's private practice, but also in the county system. We're associated with LA County and with Rancho Los Amigos, which is a national rehabilitation center. We have a high percentage of Hispanics, and we also have a good number of African American patients. So we've looked and studied those patients, and we're trying to provide expected practices and high-level care throughout the county system, which is a huge catchment system. At any rate, so one of the problems that we face with taking care of minority patients is that they tend not to be in clinical trials. So if you think about Americans, they represent 12% of the US population, but only 5% of the clinical trial participants. Likewise, Hispanics make up 16% of the population, but are only 1% of clinical trial participants. So we are handicapped in that we don't know how they respond to our current medications. So these are things that we're trying to address. There's also issues with trust and societal issues. So Dr. Amezcua recently developed a film trying to, Hispanics have perception issues. They, their religion, their perception of the disease probably differs in many ways from Caucasian Americans. For instance, there's a belief that strong emotions may affect their MS. And so she's been looking at that and looking at ways to educate effectively for these groups. I would say, the issue with mistrust is in both of these populations. There have been some very concerning studies that look at, whether these patients think that the doctors are doing something wrong, and there's an increase versus Caucasians. So all of these things, we're trying to decrease the barriers to MS care by studying it more and by looking at ways to educate and ways to help doctors enroll patients in trials, along with a lot of other things, including remyelination, which Dr. Eve Cullen is doing, thanks to Race to Erase. I'll stop there.
Thank you, Dr. Burnett. Next is Dr. Vijay Yadav speaking to us about lifestyle changes to help slow MS progression.
Hi, everyone. First of all, I think I would like to say thanks to Nancy and Race to Race MS Foundation for supporting not only this wonderful research which has been ongoing for the last 25 plus years, but also the effort that you, Nancy, dedicate to make not only us inspired, but everybody else, I think you have made a huge difference, and no words can describe that. I think it's just, I want to definitely offer my gratitude towards that. And putting this panel to have the patient's access to this kind of information from this expert panel, that's really a very, very unique thing, which I'm not sure anybody, most places don't really have this kind of access. So thank you for that. Having said that, I think of course. And having said that, I think what we've heard from the panel so far is mostly about the disease-modifying therapy and how what we are doing for progressive MS and like the role of other factors which impact MS. So I think one thing that we have seen in the last 20 years for sure, our patients have had definite access to disease-modifying therapy, which has tremendously improved the overall disease control. But one thing which people are still sort of skeptical about is medications and what can they do besides medications. And I think lifestyle factors can really play a big role in improving the overall quality of life of a person. And when I say disease control can really achieve very effectively with a disease modifying therapy, there are aspects of MS where we can improve that by changing the lifestyle. For example, like fatigue is a very common symptom. And you know, fatigue, it's multifactorial, and there's no one reason that one would be fatigued. And you know, you can come with lots of examples why it could be affecting a person. But one of the factors, you know, which is extremely common in our country now, unfortunately, is obesity. So the connection of obesity and fatigue is huge. And like right now, if you look at the US population, I would say more than 70% of the population is either overweight or obese. And it's not just general population, it's affecting the MS as well. And I think connection of obesity and fatigue is a huge, and with obesity comes this entire spectrum of disease called metabolic syndrome, which includes diseases such as hypertension, diabetes, high cholesterol, heart disease. All of these factors actually impact MS adversely. In fact, there has been really good surveys and like studies looking at MS patients, how they do with the presence or absence of vascular diseases factors or these diseases which like, you know, mostly comprise the metabolic syndrome. So there is clear data that a person with MS who has any of these vascular diseases factors such as obesity or hypertension or high cholesterol, diabetes will do worse. They will have probably higher progression of the disability compared to a MS person who's otherwise healthy. And that data actually is pretty profound. And it shows that people will start to become disabled or they'll start to use some kind of walking support or walking device within like, you know, much sooner than a person who's MS patient who's otherwise healthy. So there could be as big as 6-year difference between walking disability between, you know, patient with disability and patient without, vascular diseases factors. So I think we can impact these factors very effectively. And the way to impact these factors is by targeting what leads to obesity. And I think that's where the lifestyle factors play. Diet, biggest factor, exercise, another huge factor. And I think between the diet and exercise itself, I think if we can tackle that, we can really improve a ton of problems that our patients have. So I think that's something which we really take, and I'm sure all the panelists here, you know, their centers, they take huge interest, and the research that we have done here in whether it's a diet or exercise or looking into improving fatigue, all of that really plays a huge role. And I hope that, you know, we can convince the people to really invest into their health in general, which will improve their overall MS as well, and potentially actually decrease the disease progression. So I think I'll probably just stop there because, you know, we can go on and on and on, but I think it will be good to get the questions from the patients also. So thank you.
Thank you, Dr. Yadav. Next is magnetic resonance imaging and multiple sclerosis. Dr. Nancy Sykott.
Thank you, Claudia. And thank you, Nancy, for your leadership for these many years and for a wonderful event. I'm here at Cedars-Sinai in Los Angeles, so I was able to make the trip up to the Rose Bowl and enjoy a lovely evening. So thank you.
So glad you came. I'm so glad. Next year I want everybody else to be able to be here in person. It's kind of hard not to have everyone, but I love that you were there too.
Well, I'm sure everyone else on the call feels the same way. So thank you again. So I'm going to talk to you a little bit about something that every patient, I think, has an experience with. Anyone living with MS has had an MRI scan. And during the course of my career, I've seen MRI take on an increasingly important role. And I think just as we have developed disease-modifying therapies, we really focused on using tools like MRI to make a diagnosis early in the course. You heard Dr. Hafler talk about even identifying people before they develop MS. But as time has gone on, we really have recognized that the sooner we diagnose MS and begin these amazing treatments, the better patients will do in the long term. So MRI has played a really key role in helping us to identify those lesions that appear within the brain and the spinal cord. But at the same time, we recognize that sometimes those spots that are seen are non-specific. So not everything that shows up as a spot on your MRI is an MS lesion. And this has led to sort of the opposite problem that we had in the past, which is people not getting diagnosed too soon enough. Now we have people who are actually misdiagnosed. And we've done work in our center and at other places that have indicated up to as many as 20% of patients who come to an MS specialty clinic who think they have MS turn out to not have MS. So for all of the work that we're doing to try and identify good treatments, prevent progression, and so on, really starts first and foremost with making sure we have the right diagnosis. So through leadership at the Race to Erase MS and my colleagues in the NAMES Cooperative, we've been developing new biomarkers that will help us really, we hope, make a very accurate diagnosis at the very first signs that someone might have MS, or even before they've had a symptom, as we were hearing about before. So I just want to emphasize how impactful the resources that we've received through the pilot studies and the Young Investigator grants to allow us to move this work forward. We now have a large NIH-funded study at over 11 centers to validate some of these biomarkers. At the same time, we're leveraging this data that we're collecting in these 400 patients to identify newer biomarkers. And these are things that may help us understand who's going to be getting a worse outcome from MS. And if we could identify people at the very beginning and understand their prognosis, this could be very helpful in targeting our therapies and tailoring our therapies. Because we know that some people do very well. I think Nancy is a good example of this, do very well living with MS and really don't need to be on medication potentially. Other people very rapidly will develop severe disease. And so we're using our MRIs along with some other biomarkers like serum biomarkers to try and identify people early on and target and really tailor their therapies appropriately. So I think what we're seeing with MRI, it really gives us a snapshot of the pathophysiology in the living patient, and we see it as it evolves over time. And we can also see how our therapies are affecting those changes. And so it's a really powerful technology. And I think with some of the other advances we're having with these serum biomarkers, so blood tests, we can imagine in the future that we'll be doing a combination of an MRI scan, a blood test, and looking for these other maybe informative prognostic factors, something called paramagnetic rims, which are these spots that appear that not every patient with MS has, but people who do have these kind of biomarkers may end up needing more aggressive treatment from the outset. So I think there's a lot of exciting work that's going to be taking place in the future for diagnosis, prognosis, and then finally, I would just say for therapeutic advances, where I think we're going to hear a little bit about neuroprotection and remyelination. And we want to be able to understand how these therapies are working in the living patient. And so newer markers that will identify these positive changes will be coming, we hope, from imaging that will really guide us to understanding the best therapies going forward. So again, I think I'll stop there and I want to thank everyone. It's great to see everyone and I look forward to dancing on the stage next year. Thank you, Nancy.
Thank you.
Thank you, Dr. Sakat. Next, we have Dr. Rhonda Voskuil to speak to us on impact of sex hormones on immune function and MS.
Hi, well, thank you, Claudia, for narrating. Again, you're wonderful, true pro at this job. I also want to call out Nancy Davis. You know, the rest of the country may not be aware how hard the things that she's doing is. We're in California, and we've had tremendous restrictions, and not many have the vision and the innovation and the courage to put on events like she did. I mean, this isn't Florida or Texas. This is very hard in California, and she did it. So I want to say congratulations there. I also want to say the other innovative part is the whole Center Without Walls. You know, UCLA is new to this, and we came in a year or two ago, and we're very thrilled. You know, it's been really amazing to see all the researchers coming together. They have on the symposium day and talking in small groups and advancing things. So I think if you're interested in, you know, real innovation, this is the place to go. I think you know, Nancy's that sets the tone with the innovation and the courage to really do new things, and you can see that in various aspects. But I've actually been asked to talk about something very important, I think, and I think the National Institutes of Health and the world really is recognizing this, and that is sex differences in health and disease, and how they implicate these diseases, and can this be a really invaluable clue to figure out new treatments. And I'll just give you the way this has evolved. So sex differences in particular are known to occur in the healthy immune system. They're known to occur in the brain. Substructures differ in regions of the brain between females and males. And so what happens to disease? Well, lo and behold, they act differently. And I'll give you some examples. And I do believe MS is leading the field, but we know that, for example, females are more likely to get lupus. They're more likely to get rheumatoid arthritis. Even Alzheimer's disease, 2/3 of Alzheimer's disease patients are women. And so the point is, if we could just figure this out, either by looking at sex hormones or sex chromosomes, we could identify things that would be beneficial actually to both women and men. So let's talk about, and to this end, the NIH has passed a policy now that all NIH grants have to look at sex as a biological variable, a very important one in regulating the disease. And so I'm thrilled to see how far this has come. I'll focus now on MS specifically, and that is that females are more susceptible to MS. This has been known for a very long time. By the number, it's about, it was 2 to 1, now it's about 3 to 1 more females to male. But the other interesting thing is that when men get MS, they do worse. So they have faster disability accumulation. And so the question is why? Because if we could understand, we could prevent women from getting it, or we could prevent men from doing worse. So this is important for both sexes to try to understand this. Very big implications. Now, what could it be? Well, we all know that there are things that happen in it with hormones that are important. For example, there are effects of pregnancy on MS. There's effect now emerging. There's effect of menopause in MS. Menopause appears to make MS worse. Also andropause, we've worked on this a lot as well, that dropping of the testosterone levels very slowly during andropause looks to be deleterious. Now, some of the ways this works is we focused quite a bit on this neuroprotection, neuroregenerative aspect, and we've shown that estrogen can cause remyelination, and it can regulate the immune system within the brain to make it less inflammatory. It's not surprising that testosterone could be good as well, because testosterone is converted to estrogen in the brain. So andropause and menopause are both bad for neurodegeneration and for possible repair. Now, just to last but not least, there's more to sex differences than hormones, and that's also sex chromosomes. So females have XX and males have XY. And to that end, we and others have made major advances in finding and identifying an X gene that is involved in this really pro-inflammatory response, the immune response in these T lymphocytes and other cells you've heard about in females as compared to males. There's also an element where it matters where you got your X chromosome from, the parent of origin. So from the boys always get their X chromosome from the mother, but girls can get it from the father or mother. So again, very important discoveries being made for sex hormones, their ability to cause remyelination and repair. There's very important discoveries coming out for the X chromosome and its role in advancing and making a very deleterious autoimmune response. So I'll go ahead and stop there and turn it back over to Claudia.
Thank you very much, Dr. Boswell. Next, treating immune medicated depression and pain, Dr. Adam Kaplan. Are you with us, Dr. Kaplan?
He's muted.
Oh, can you unmute yourself?
Yeah, it's too bad because what I just said was brilliant and I'll never be able to recreate it. But you guys missed it, but I'll try to go on with a second effort. So I, like other members of the panel, want to thank Nancy in this case for her personal support. This topic this year is very personal to me. My nephew died in an accidental drug overdose a month ago, and Nancy was very supportive just in how she has been open in dealing with her loss as well, but also for destigmatizing the diseases of depression and addiction, and like David Osmond, demonstrating how to celebrate life as they did last night, while simultaneously working to help people's lives. So that's truly leading by example on both fronts. So I'm going to start with the pain. Unfortunately, as it touched my family, there are 70,000 deaths from drug overdoses in this country. That's 190 people die a day. And that has increased from 15,000 in the year 2000. So for the past 21 years, this is 4 times the number of deaths from motor vehicle accidents and 5 times from homicide. Why do I bring that up? Well, 50% of people with MS have chronic pain, and 20% of people with MS report using opiates. And the majority of them, so that's 15% of all people with MS, report daily opiate use. And so this is, a big problem. It's a not so silent epidemic, although because of the stigma, people don't give it the kind of traction it should get. In the limited time we have, what I can tell you is people are working on novel treatments. A lot of research is going into CBD, for instance, for its potential use in chronic neuropathic pain. We're not there yet to say that we've got good data, but it's being worked on. The other thing I would mention is that as a take-home message, the goal is not zero pain. And unfortunately for those people who have MS and have chronic pain, if you were able to get it down to zero, you would have probably by now. So the goal is just to get it as low as possible to then allow you to function and go out and find, a purpose for your life and engage. Because if you just sit home with the pain and that's all you have, the pain will be, magnified 1,000 times. So the goal is just to try to get it down low enough for you to then go off and have engage in your life. In terms of the immune-mediated depression, well, there's no better example of immune-mediated depression than what's going on now. So it turns out a month ago out of Harvard, there was a study that looked at people who have been gone through COVID-19, who have been infected with the SARS-CoV-2 virus. And it turns out over 50% of them had moderate to severe major depressive disorder. And that's again, because inflammation has an effect on the brain, and that the brain is kind of the sensitive canary in the coal mine for what's going on in the rest of the body, and clinical depression is what results. So it is important. Depression's the #1 correlative quality of life for people with MS and their care partners. It worsens the MS. And has significant morbidity as well as mortality. It's also important to know it's a bidirectional relationship. So MS causes the depression worsens the MS, treating the depression improves the MS. And now there's been a series of studies that have shown that depression is actually a risk factor for getting a number of autoimmune diseases. It's now been shown for MS, that was the first, then inflammatory bowel disease, lupus, and now rheumatoid arthritis. And in all of those cases, it is the case that depression is basically a state of having elevated cortisol. Cortisol is the brake of the immune system. So if you keep riding that brake and then you go to pull it, if you have an infection and you want to slow down the infection, it no longer will respond. So that's a big problem. I will tell you that now also what's interesting is greater than 60% of people with depression without MS have been shown to have an overactive immune system. So the good news is that this is opening pathways to now develop novel treatments, many treatments that will overlap with some of the treatments that are involved for autoimmune diseases, including anti-cytokine treatments and the like. And you may have heard about ketamine and psilocybin. Interestingly, they both have potent anti-inflammatory effects. So I wish I had news of this is now the treatment for immune-mediated depression, but I will tell you that the depression is a product of the inflammation that goes on both with COVID and with MS. It's not a personal weakness or flaw, and it is treatable. So thanks for your
Dr.
time.
Kaplan, your voice got messed up. You can't hear you at all.
Yeah.
Something happened in the last 30 seconds. Your voice is muffled.
I guess.
Now it's really bad. I don't know what's wrong. Something happened with your microphone or something. There's some echoing and we can't hear you.
Okay, that's technology for you. Is that better?
Yeah, that's perfect. I want to go 30 seconds because what you're saying was really important, but we couldn't hear you.
Well, I think the last part of what I was just saying, and I apologize for the technological failure, thus is our life here in this, post COVID world. But well, I think the main thing I was just trying to say is that, the depression that comes with these autoimmune diseases, be it COVID or MS and the like, is not a weakness. It's not a character flaw. It's just another symptom of the disease, and that treatments are coming. We don't have FDA approval of any treatment for immune-mediated depression, but we're working on it. And so I'm hopeful that hopefully in the next year or two, we might have better news about specific treatments. That was pretty
Can I ask you one quick question? What
Sure.
other immune diseases are affected by these high cortisol levels caused from depression?
Yeah, so it's a great question. And so the first was MS, the paper was published showing MS is that depression is a risk factor for getting MS, and then was followed by inflammatory bowel disease, Crohn's, and ulcerative colitis. What's interesting there is they actually were able to look, and if you had treated depression, you didn't have an increase in risk of getting MS. It was only untreated depression. And then lupus, and finally rheumatoid arthritis was the most recent one.
Oh, okay.
But it's a general phenomenon of what happens. And again, as had been mentioned previously by Dr. Hafler, Epstein-Barr virus is a good example of something that if your immune system is overactive and you get Epstein-Barr virus and you can't quiet your immune system down, you'll be in trouble, as the work he's done and others have doing to show, that can be one important cause of MS.
Thank you,
So-
Dr. Kaplan.
Sorry about the wasted time there, Claudia, but
No.
thank you for the patience.
That's
No.
good.
We appreciate you. All right. And before we go to our lightning round to answer the collected questions, we would like to hear from David Osmond about living with MS.
Well, thank you, Claudia. Certainly. I don't want to take more time than is necessary, but I'm so grateful to be even a fly on the wall at this session. In fact, there are many people who have sent me messages saying they couldn't make it and they want me to take notes for them. This is probably the only forum and arena where I will ever get mistaken as Dr. Osmond. So thank you for that compliment today. That was, and compliments to you, Claudia. As always, you're doing a phenomenal job. Kudos to Nancy Davis. Last night was phenomenal. As always, you and your team, Liz, Sears, everybody, they pull off the impossible. And it was an incredible event to be a part of, not just to be there to witness, but to also be a part of on stage. It was a thrill of a life for me. And so thank you for the opportunity to be there, to perform, to sing. We had our release concert for our brand new album. I have a big band. It's called the Osmond Chapman Orchestra. And it just launched yesterday. And to give you feedback, I just got word about an hour ago, we're in the top 5 on iTunes for our record today. So all thanks to Nancy Davis. Thank you so much. So I like to think that the event put us over the top.
You're so fabulous. You're like a Michael Bublé kind of.
Thank you.
But
Thank
just
you.
amazing with your own iconic talent.
I really appreciate that. Thanks. The music hopefully speaks for itself, and we have had a great time performing it. And the audience couldn't have been more gracious. And obviously everyone is there for the cause of supporting MS and this great foundation. And what I love is just being a part of this great race for so long now and seeing all the incredible things that you're doing. So I certainly don't want to take too much time, but as someone who benefits from this foundation, I'm here to support you, but I feel like I get more support from you than I could ever give, because you're changing my life and millions of people's lives worldwide. So thank you to every single physician, the true doctors on this panel. Thank you for all that you're doing. I wish I had the prefix. I'll work on that. My story is one that lives with MS. Like many people who are diagnosed with MS between 20 and 40 years old, I was no different. I was 26 years old, and it came on very aggressively. I was familiar with MS. My dad, Alan Osmond, who you're not old enough to remember the Osmonds, nobody on the panel, but he was the oldest of the singing Osmonds, and he has been living with MS for about 35, 36 years. I only knew my dad pretty much to have MS. And having an example like my dad has made all the difference in the world. And having examples of so many in this realm has made a difference in my life. When you're talking, Dr. Kaplan, it's like I get emotional. You're speaking to my heart. Dr. Ron Vosko, when you're talking about those things, it affects me. Every single physician, I'm on the edge of my seat. I'm taking notes because I learn from you, and I benefit from the hope that you're giving me. I remember my dad telling me years ago, Annette Funicello, who was a dear friend of his, living with MS, told him, Alan, it's not the disease that gets you down, it's the lack of hope. And you give hope to so many people, including myself and my family. I have a large family, and I've learned that my family is so much bigger than I ever imagined. It's all of you, and it's all of you that are listening. I'm here with you. I understand you. In fact, it's almost on a weekly basis, I meet someone new who's either just diagnosed with MS, and they're looking for answers. They're looking for something to hang on to, that hope. And even though I'm not a doctor, I am grateful to be associated with all of you, because you do give that hope. Even last night at the race, I met a young girl who was just diagnosed. And it's incredible to know how big of a problem this is in our world, but how big of a solutions we are coming up with. And thanks to the race, even behind the scenes, kind of a silent warrior, you're able to be a part of so many clinical trials and therapies that are actually on the market now because of the funding and the research that all of you are doing. So it's inspiring to be a part of that. I have a wonderful little family, 3 kids, two girls and a boy. My wife and I, we've been married for 14 years. I proposed to my wife from my wheelchair, and she said yes, in sickness and health. Miracles happen every single day, and I'm living that miracle. And even though I wake up every day, and honestly, to what you were talking about, that pain, I feel like I got hit by a car almost every day I wake up. I know what I can't do, but I also know what I can do because of that. And it sounds crazy, but having MS for me is one of the best things that's happened to me in my life, because it gave me this shift of perspective. And it's not easy, and it stinks, and it's hard. It's tough. As my grandpa said, life's tough, but so are you. So be tough right back. So I hope to live up to the examples that people like my dad have given me, so many of you, and the patients that you're treating and helping. We're a family. We're in this together. And it's nice to know I have a village and people that understand me as well. So thank you. I won't take too much more time. I'm here to learn from you. So I'll zip it. But thank you again, and I champion you for all you're doing.
David, you're amazing. You are.
Yes, thank you, David. Thank you so much. And now for the exciting part of the program, a lightning round to answer any of the collected questions. Dr. Waband, I think you have the questions.
Yes, I have collected the questions. So thank you to the audience to be very participative here on messaging and chat. So remember, you can send us questions through the chat or the Q&A, and that's going to be the main way we can channel the questions to the panel. So the first question I want to highlight, because I think it's important for all of you on the call today: how can I share the recording of this presentation to my other MS friends that were unable to attend or log on today? So the good news is that this is recorded. This will be on the Race to Erase MS website. And I know that there will be additional emails circulating to potential participants to actually be able to log on and listen to the whole panel. And it's very important that today you are joining this panel, because that's a good way to learn about top-notch science, changes in hope. And thank you for joining. So I will start with one of the questions that was sent to us. So as discussed, there's a decreased COVID antibody response in MS patients taking Ocrevus. What is the efficacy of the COVID vaccine if you first start taking Ocrevus many months after receiving a COVID vaccine? So what we have done in the past 6 months, we have suggested to patients who are about to start a treatment like Ocrevus to actually wait at least 4 weeks after they were fully vaccinated. So after they had received either the second injection, if it was a 2-shot vaccine, or after their main injection for the J&J vaccine. And that's with the thinking that once you have your immune system boosted by the vaccine, then you can go on receive medications like Ocrevus that will decrease the B cells. And we don't expect that decreases the efficacy of the vaccine. And I want also to emphasize that. I want also to. to emphasize that we think that medication like Ocrevus may decrease the effectiveness of the vaccine, but we don't know for sure. And this is something that is currently being tested. So, I think that we need to just learn more to be able to make final recommendations. So someone was trying to talk?
Yeah, I was just going to make a comment there. I think there's an important point. I totally agree with Emmanuel said. We do the same thing on patients who are about to start Ocrevus. We very much want patients to get vaccine first, and it's almost certain they'll have a good immune response. MS itself is not a risk for getting the vaccine. Let me just strongly encourage every patient. I cannot think of any medical reason not to get the vaccine. The neurologic complications, the long haulers we're seeing with this, even mild cases, are really quite striking. So I urge everyone to please get the vaccine. That being said, related to Ocrevus, if you measure your antibodies, excuse me, after the vaccine and you're on Ocrevus, there's about 20% or less of the patients develop antibodies. So if you have that test done against a spike protein, you will probably not have antibodies. However, that does not mean that you're not protected, because there's both the T cell response, which directs the B cells to make the antibodies, are extremely important. And we're just in the process now of measuring T cell responses in B cell depleted patients who are getting the vaccine. And again, we've just started generating those data. I suspect that there will be an increased risk of infection if you are on B cell depletion, but to the extent of what it is not yet clear. So it's really an open question. But again, if you have the antibodies measured and they're not there, it does not mean you're not protected, because the T cells are still being generated. You're likely to have some protection.
I'd like to just say that I was initially very concerned that so many patients were not getting vaccinated, but yesterday in clinic, we saw 25 patients, and the vast majority had already been vaccinated. I'm so proud of them, and I'm so glad that they're taking advantage of this. I second Dr. Hafler. It's extremely important to go ahead and get vaccinated. You don't want this infection.
So the next question we have is, and maybe that's for Dr. Weiner, any update with the BTK inhibitors and how does it work? Anything new for primary progressive MS? Howard, are you muted?
Muted.
Yep.
While he's jumping in, I can just say that we're doing both trials for progressive MS patients with the BTK inhibitors at USC, so feel free to contact us.
Yeah, so what I was going to say, and Margaret, I'll turn it back over to you. I don't have any more specific information, but Margaret, why don't you answer the question, because you're doing those trials?
Right, so we know it affects inflammation. I don't think I can explain the whole thing very well just off the cuff, but it is a part of the inflammatory pathways that the BTK inhibitor involve. And we've got 2 trials that we'll be enrolling, so that should start very soon. Wanted to mention also that somebody mentioned the stem cell. We were in the initial phase 1 stem cell trial, and it looked very positive. I have not seen the data. Dr. Pelletier just hinted that it's been very positive, and so we hope to roll on to different states of that research at USC. So stay tuned.
So when you say stem cell, what do you mean? I think the word's often used and it gets very confusing, at least to me, I think to many patients. So there's hematopoietic stem cells, which are basically bone marrow transplant, which one receives very high dose Cytoxan and wipes out the immune system. This use of Cytoxan first developed by Howard Weiner back in the 80s. That's incredibly effective with a lot of toxicity. So that's one type of stem cell treatment, but that's really bone marrow transplant, probably we should call it. And then there are people who are trying to inject stem cells, I'm not quite sure what type of stem cells, into the brain, and that's a very different type of therapeutic approach, of which there are, I think, very little data.
Thank you for that clarification. These are stem cells that have been produced. They're sort of available off the shelf they don't require chemotherapy or anything to knock out the person's immune system, and they are being injected into the central nervous system. So they're being put in with the CSF.
Are they mesenchymal stem cells? Are they made from the person's bone marrow, or they're more generic? Are they individualized?
They are, I think that they're mass produced, so they're not necessarily individualized.
I see.
How do they deal with it? How do you deal with rejection, allogeneic rejection of foreign tissue?
I think that they've managed to avoid that with these cells.
Is there a company that's doing this?
Yeah, and I am blanking on their name.
So on the topic of stem cells, since we're on that topic, there were a couple of questions. Do we have better hopes for stem cell treatment than being able to get, for example, an mRNA vaccine for MS? The question is also that there's been some advancement in Europe and Israel. Is there anything viable on the horizon?
So I can address that a bit. I think that the stem cells that I understand may be the most promising are mesenchymal stem cells, where they make stem cells from the bone marrow. And there was a report out of Israel 2 years ago at the ECTRIMS meeting suggesting that intrathecal stem cells made from mesenchymal stem cells helped MS patients. It was a controlled trial. And then there's a company that's been testing 4 or 5 patients with these mesenchymal stem cells. So that's ongoing. I don't know where the trials are now. I don't think we want hematopoietic stem cells or embryonic stem cells, but these mesenchymal stem cells are being actively studied.
And the basic thought from the papers published years ago in the EA model is that they migrate into the central nervous system and release anti-inflammatory factors and cytokines, which may end up treating the disease. That's most likely how they work, if they work, as opposed to regrowing back brain.
Right, exactly.
So questions relating to the mRNA vaccine. What's the current, because we've spoken already a fair amount about that through Dr. Hafler, what's the current state of developing a vaccine or other strategies to cure MS? Considering how quickly Big Pharma created, tested, and tried vaccines to stop the spread of the coronavirus?
Yeah, so I addressed that in the chat. Thank you for the question. It's a wonderful question. And my initial response, actually, I responded to it in part already, but strategies to induce immune responses, vaccinations, we know how to do that. Strategies to block immune responses, that's been much more problematic. So you can't equate one with the other. I discussed the mRNA myelin approach. We will see. I think the key to MS is really treatment and preventing the secondary inflammatory events, the spreading of the immune response that occurs.
And so I know that some questions may have been answered in the chat, but I'm not sure everybody can see it. So that's why I'm bringing up some of these questions. So remaining in the COVID vaccination arena, a patient is asking, I have received the Moderna vaccine and had a rash, and every time I inject myself with Rebif, I get a reaction at my injection site and pain in my arm. I'm a month past my second dose. Is this something I should be concerned about? And the short answer is not that I know of. Anybody would disagree on the panel with the short answer? No, okay, very good. So the next question is, what are your thoughts or perspective on primary MS? Why MS progresses differently in these cases, and best and or future treatments particular to progressive MS. So I think we've touched base a little bit about some of the treatment approach for primary progressive MS, but maybe Dr. Weiner, you want to answer what's different about primary progressive MS processes?
There's two types of progressive MS. One is called primary, one is called secondary. It may very well be that for most of the primary progressive MS, it's just a form of secondary progressive MS where you didn't have attacks. So I think the general field is thinking that primary and secondary progressive MS may be similar. They may be similar. As far as therapy is concerned, progressive MS is one of our hardest types of MS to treat. The drugs that are used for secondary progressive MS can also be used for primary progressive MS. So the answer is it's probably all one form of MS called progressive MS. One might have more clinical findings early than others, but often the MRI looks the same, and that any of the drugs for either type could be used to try and treat people.
Thank you, Dr. Weiner. I will add also that there are different treatment approaches that are tried so often with progressive MS. The companies have had a tendency to try drugs that were approved for relapsing remitting MS to see whether they had an effect in progressive MS, and that's how Ocrevus, I guess, got approved for progressive MS. After I had a Race to Erase MS pilot grant a few years ago to look at N-acetylcysteine at high dose and tolerability and possibly an impact on oxidation. So it's an antioxidant, and I am now funded by the Department of Defense to do a trial in progressive MS with N-acetylcysteine that will start probably at the end of the year. So stay tuned. The next question I wanted to bring up is someone is asking, I am a biracial, mother white, father black, but most people think I am Asian, although I don't have Asian ancestry. I have MS and the disease runs in white. Can I participate in a medical study if 50% not black enough? Margaret, do you want to answer?
Oh, there are several databases that are involving patients, and I'm sure that you would be welcome. It's true, the admixtures are on a spectrum, and so I'm sure that you could sign up for one of those registries. I wouldn't think that you would be blocked at all. Usually,
yeah, go ahead.
Usually patients that are enrolled in these self-identify as African American, but I think if you're an admixture, that's okay too. Can I just clarify the stem cell thing? Sorry that I didn't have the information before. This is from Neuron. These are mesenchymal stem cells. They're autologous. They're known to secrete neurotrophic factors, and they feel that by injecting these, this is a secondary progressive trial, that they would possibly help the survival of neurons, so that's the theory behind the Neuron mesenchymal stem cells. So it's looking at safety and efficacy.
Thank you. Another question here about what helps pain and spasming in the feet. So I don't know whether Adam or so Dr. Kaplan or Dr. Yadav, you want to answer about that question?
Well, can you repeat the question?
So the question is, what helps pain and spasming in the feet?
So I mean, there are medications which can be used, and others, not just medication, strategies can be used to help with the pain as well as spasm. There are antispasmodic drugs which are like well used for like, a long time. And then there are pain medications, specifically neuropathic pain medication, which are also FDA approved. So they can be easily used. So I think you have to work with your doctor to identify which drug may work best for you, considering like many factors which can be unique to the individual. So there are options.
I would agree and only add excuse me, and only add that, it's, I'm as guilty as anybody better living through pharmacotherapy, but for spasticity, stretching can be very helpful, finding, what works for you. Some people find acupuncture for, pain can be extremely helpful. So a lot of it is just needing to find what is the right combination for yourself. That's all. I agree 100% with what Vijay said.
I also find that my patients who aren't getting good night's sleep tend to have a lot more pain. So there are a lot of lifestyle contributors that can increase pain in people with MS, and really all of us, right? If you think about it. So don't forget about checking your sleep habits, making sure you're getting at least a good 7 hours a night, which is known in people in general to be associated with less shrinkage of the brain over time. People with MS often have occult or undiagnosed sleep apnea, and they don't always present with the same kind of classic symptoms as we think about or we learn in a textbook. So if I send my patients who wake up feeling tired and wake up all night long to get a sleep study, we often find they have sleep apnea, which can contribute to pain as well. Then getting routine exercise, I find, also helps a lot of my individuals with MS who notice pain and spasticity or tightness. So I think all really important contributors.
No, I agree with Dr. Maury completely. Pain is multifactorial and everything has to be addressed. There's no one answer. Medications are there, but it's whole other factors can contribute. They need to be addressed as well. So I think working with the doctors is the best way to. But yeah, don't just suffer. Please reach out to the doctors. They'll help you for sure.
Yeah, I'm sorry. I just can't stress enough how I wish I'd said what Dr. Maury had just said. Those are key points. The only other thing that comes to mind as well is while we're so preoccupied with drugs, people often don't realize that if you take painkillers day after day, you can also induce a painkiller induced increased pain. So if you find yourself, I'm taking a little and it's helping, then the pain gets worse, and I take more and it's now getting worse, you're probably in this cycle where you're actually making it worse with the painkiller. It's just something to keep in mind.
So I've been attending forums, supporting fundraisers, and participating in MS walks for over 10 years. How close are we to finding and sharing a cure? Dr. Weiner, do you want to answer that one?
So this is
write a book, Howard.
That's right. Well, I wrote a book called Curing MS. So the word cure is a very interesting word. It's used in medicine. It means different things to different people. And I frequently had my patients, is all the doctors have their patients come in and they say, hey doc, when are we going to have a cure? That's kind of the question. And that's what we're trying to do. So the question really then is, what do you mean by cure? Because there's different types of cure. So I think that there's 3 types of cures that we're working on and that we're trying to get. The first is that if someone comes down with the disease, we stop it in its tracks. It doesn't go any further. There's no more progression. There's no disability. I have many people who have had MS, as all the doctors had, for many years, and they've been on therapy and they're living normal lives, they're having kids. And I think that's a type of cure. It's stopping the disease in its tracks. You need to take your medicine, but you don't develop disability and you can live a normal life. You can have a family, et cetera, et cetera. That's not true for our other neurologic diseases like ALS or Alzheimer's, for example. So that's cure number 1. And I think we're curing people right now with that definition. The second definition of cure is to help someone with their disability. In other words, someone has disability. Can you take away the disability or make it better? Now, this is harder. We heard some things today about spasticity and sleep and medicines, et cetera. There's myelinating therapies and other drugs that are being tried. So we can't take away people's disability. We can lessen it. And many people are working on that. So we don't have that yet. The third cure, and sometimes Dr. Hafler and I, we like to talk to each other about everything. And we sometimes say, well, when we're in heaven in 100 years from now, and I'm sure we're both going to be in heaven, there's no question about that. And we look down on MS, how will it be cured? And we kind of both agree, and Dr. Hafler talked about it, that there'll be some kind of vaccine or some kind of treatment that'll stop people from getting MS, whether it's EBV vaccine, whether it's the gut microbiome or whatever. So that's the third type of cure, to stop it from ever happening. And we're working on that. And some of the things that Nancy Davis is supporting aim for that ultimate cure that we're doing. So when will we get a cure? Cure number one, we're doing, stopping the disease. Cure number two, reversing damage. Tougher, but we're doing it. Cure number three, stopping it from ever happening. We know clues on how to do it, and we're working on that. So a lot of excitement.
Thank you, Dr. Weiner. So two kind of related questions. Can you speak to being JC virus positive and the newer, more robust drugs on the market today? And as another kind of related question, the journal JAMA Neurology recently reporting that a 70-year-old man with progressive MS died after being diagnosed with PML, and doctors noting that the older age likely played a role in the PML infection. So anybody wants to take this question? Otherwise, I'm happy to. So I can start answering.
I would just say that one of the things that we're studying in the context of our NIH Human Immunology Project Consortium grant is the frail elderly and the immune system. So that clearly, as one ages and when people study this, I keep asking what do you mean by elderly? It keeps changing depending on how old someone is. But individuals who are get into their, for the frail elderly who get into their 80s, have a markedly decreased immune system. There's a lot of discussion with influenza, for example, and if you're over 65, which is not what I would call elderly, but if you're over the age of 65, you're eligible for a different influenza vaccination that has either a higher dose or with adjuvant. So clearly your immune system goes down with aging. I don't know this particular case if this individual was on immunotherapy with MS. MS is not a risk factor for PML, for the JC virus, but we used to see it before there was immunosuppression. So yeah, it's risk, but remember with any treatment, risk-benefit ratio. So it's not a reason not to do a drug, depending. We can discuss Tisabri and all that. Ellen, you're shaking your head, so you should respond.
Yeah, so I go ahead, Dr.
I was just thinking that, I mean, when I read the, this case, of course, we don't know the patient in particular and the pros and cons, but I always talk to my patients as they're getting older about what we expect of the medications, what our goals are, and how their individual risk factors might be changing for having a complication of the medication. So, I think especially as we look at the anti-CD20 therapies, work that came out of Sweden about a little over a year ago, even looking at increased hospitalizations with pneumonias and UTIs and things like that with these medications over time, we have to imagine that just like COVID-19 bad outcomes are enhanced in older individuals, we also would expect that ongoing immune suppression in general would be potentially more risky as people get older. And I mean, I think there are some interesting studies looking at randomizing people with MS to discontinuing medication versus staying on as they're getting older. And those will be really interesting preliminary work to help advise people as they get older about when it might be appropriate to stop their disease modifying therapy.
We're about to start a clinical trial with Genentech. Patients with RIS, who again is at MS probably, will be treated for a year and then stop, and we'll follow the patients in a randomized trial. So Glasgow, just ask the panelists, just because, I have someone in their mid 70s and they said, do you put them on Ocrevus or not, or B-cell depletion? Go, it's tricky. Where someone very young, absolutely. So my question to the group is, how long, just what you're asking, Ellen, how long should we treat? Do we need to treat? We know with Tisabri, once you stop, there's a rebound and it stops working. You're blocking T-cell traffic to the brain. But a major question in the field is if you do B-cell depletion. And again, the B-cells are not depleted. They're not in the blood, but they're still in the lymph node and there's still B-cells in the nervous system. But when you use with these treatments, how long do you need to use them for? And that's a critical question. I don't know
I think
the
there are a
answer.
lot of great trials going on looking at various patterns of discontinuation. And I think clinically, a lot of us are also extending the interval between doses, particularly in those who might be more vulnerable to infections. Or for myself during the COVID-19 pandemic, a lot of my patients extended the interval. And honestly, even young people have been doing pretty well and not having any breakthrough relapses or new lesions on the MRI scan. So we may find that we can customize or change the treatment or perhaps discontinue it altogether after some period of time and then do some watchful waiting.
So I want to go back to the, and we can come back to these afterwards, but I wanted to go back to the specific question that was asked. Can you speak about being JC virus positive and newer treatments? I think that we have known a lot of things about the risk of PML, that slow brain infection that has mostly occurred with Tysabri. And now we have very clear algorithm actually how to handle patients, whether they are JC virus positive or not, and what is the level of positivity also in the blood that seems to probably determine whether there's a high risk or a lower risk. And I think that's been very helpful, and that's really something that if you are positive and you're on this drug, you can discuss with your neurologist, but we're trying to do increased time between infusions also as a mitigation of that risk of PML. So there's all sorts of strategies that are emerging, and these strategies can be considered for newer drugs like agents that target B cells, as the Dr. Maury or Hafler were discussing. Because we know that after a year or two, decreasing the dose or decreasing the frequency of injection may actually remain as effective and possibly may decrease the risk of infection. So for the JC virus, what has been seen in the cases reported with other agents like Gilenya or Tecfidera, these cases tended to occur in patients who were older, and they tended to occur specifically with in the context of Tecfidera for patients who had low lymphocytes, which typically is not really happening in most of the patients. So we have, depending on the drug, some signals that are telling us whether we're having a risk or not of PML. And we need to be vigilant in how we are handling specific medications in the context of being JC virus positive, in the context of age, and potentially other risk factors. Anybody wants to add anything to that?
No, I agree with you, Maya.
And so for medication like Ocrevus, we've not seen an increased risk of PML really, although we know that in theory it could happen. So we're keeping our eyes open because it's been on the market for not that long. So if nobody else wants to chime in, the next question for Dr. Kaplan, what do you think about ketamine for pain? Any update on insurance covering it?
So ketamine is on the list of the World Health Organization, top medications that have been discovered for mankind, largely because it is an anesthetic that doesn't cause respiratory depression. So Michael Jackson died because of propofol, another anesthetic. It has been discovered to have a number of other properties, including benefit in pain. And again, I would encourage people to consult with pain specialists who have experience in using it in that capacity. And more recently, it was approved for use in depression, treatment-resistant depression specifically. And again, my particular interest in that drug, and I started the esketamine clinic at Hopkins, is that it has anti-inflammatory properties. So again, the relationship between pain and depression is a very close one. Something that could affect both is certainly worth exploring, but it is also a drug that needs to be given by someone who has expertise in delivering it, such as a chronic pain specialist.
Next question. Hello, my mom was diagnosed with MS 7 years ago and she's 58. She tried a few infusions and they have not worked for her. She has progressive MS and also JC virus. When she has flare-up, they always give her steroids, which helps with pain. One doctor told her that steroids are not good for MS patients. Is this true? So Margaret, I think you had answered in the chat, but do you mind answering for the group?
Well, one of the things that she mentioned is that her mom is having exacerbations. And so she has active multiple sclerosis, have a lot of agents that should work to quell those attacks. So I would ask, I would hope that they would explore the agents that we currently have to see what they could use for maybe more effective. Sounds like she needs a step up in therapy.
I just wanted to chime in though, in my experience, because a lot of my patients get their, main MS care with us, but may come in from more rural areas where doctors are not as well versed in MS. I think sometimes there's a lot of confusion for what constitutes a flare-up and whether or not it represents new inflammation in the brain and spinal cord, or if it's recrudescence or recurrence of old symptoms. And there's a little bit of a language problem that exists between neurologists and people living with MS that is important to keep in mind. So because as people get older living with MS, they're actually at lower risk overall of developing new flare-ups and new spots on the MRI scan. There's an increasing risk that a new set of symptoms or worsening of old symptoms, it's less likely that those symptoms are actually due to new inflammation. And I've seen a lot of people get overtreated with steroids because they're experiencing worsening of symptoms and they assume there's new inflammation underlying it, whereas we're not really seeing on the MRI scan consistent increase in the new spots. And so we wouldn't really expect, a lot of times I think giving steroids in that situation is sort of like spinach for Popeye. You're like, yay, I feel a lot better. But it's actually not likely, treating that symptom per se. And there are a lot of risks associated with steroids, both chronically and sometimes even in short-term cases. Some of the worst things that can happen, I think, are, the steroid course causes the blood vessels in the hip joint to kind of have problems and the hip joint dies and you need a hip replacement. So personally, I'm really careful to not overtreat with steroids. I think that they can do harm. They can do good, but you have to be careful, but also to really explore potentially with an MS expert, whether these symptoms that are getting worse for her, which whether or not they're due to new spots, actually do feel pretty bad. So they deserve attention, but they may not represent new inflammatory disease activity. And in that case, it might not be either useful or safe relative to the risks to treat her with steroids, nor may they respond to these newer MS medications. It may mean that she needs, better and more thoughtful symptomatic care. And I saw Dr. Kaplan had noted, working with a physiatrist or rehab doctor and other people who might be able to help when these symptoms kind of culminate. And again, here's where the lifestyle things make a huge difference. Eating healthy, getting exercise, getting a good night's sleep. You'd be surprised, working with physical therapy, you'd be surprised how far that can take you if you're working hard on the health of your overall lifestyle.
I totally agree with what Ellen just said. It's very important to verify that it is actually new disease activity rather than a pseudo exacerbation or an infection, et cetera. Totally agree.
So, yeah, I'd like to weigh in. I think that it raises a larger question of, she's 58 and this is around the menopausal time. And there's been data showing that menopause, when women with MS go through menopause, that they can have worsening of these pre-existing symptoms. And again, it's not that they have new lesions, relapses, or any of that require anti-inflammatory treatments or steroids. It's the fact that they're having worse neurodegeneration. And so this has been alluded to a little bit, but I wanted to expand the effect of aging on MS. And we're very invested in working on this. I think there are things about aging that can't be changed, but there are things that maybe can. And we should focus on the things that can be changed. And to that, and we have really a couple areas, and that is, again, is there something about menopause or andropause that is bad with respect to neurodegeneration? Can we reverse this? And to that end, we've seen effects, on remyelination with estrogens. But there's another possibility, and that is metformin has been touted as an anti-aging therapy. There's some interesting data that was done on remyelination with metformin by another group. And that was done in a model that did not have inflammation associated with it. And so we're actually funded through Nancy Davis's Center Without Walls to try metformin treatment in a model of MS that does have inflammation. Because I do want to say some of the remyelinating therapies and these reparative therapies that could be important in older people not being able to repair. It's a little bit complicated. Some remyelinating therapies have failed to date, and that's probably because they've taken systems that don't have the kind of nerve damage with them, or they don't have the inflammation with them. And so what we need to do with remyelination is to think about all the cells that are there, not just remyelinating, but also sparing those wires that the myelin's wrapping around. And because there's a timing issue, if the wire's too damaged, you're not going to put new myelin on it. And to that end, we've studied heavily these other cells called glia or astrocytes and microglia that are very important in interacting with all of these cells that make myelin and the cells that maintain these synaptic connections. And so I think there is good stuff on the horizon if one thinks about the whole picture of all these cells and how they interact, and specifically how they go south or downhill during aging, and what we can do to focus on some things that we might be able to reverse with some of these treatments.
Thank you. One question for Dr. Sykott. How often should a patient have an MRI? And I know you've answered in the chat, but again, I'm not sure anybody else in the audience can see it. So Nancy, you want to chime in?
Sure. The way the question was phrased was an MRI with contrast. And so there's sort of two parts to this question, I would say. So contrast that we use with MRIs in general is gadolinium-based contrast. And for many patients living with MS, every MRI that you got previously probably included gadolinium. So we're using it a little bit more sparingly these days, in part because it's more expensive, and there are theoretical concerns about too much exposure to gadolinium. But in general, we use it to help us time the lesions. So if you're being newly diagnosed, for example, it can be very helpful to have the contrast so that we can see if there's new active lesions along with older lesions. And so it helps with the, give us more diagnostic accuracy, and also just to help in the differential diagnosis. So I think that's very important at the outset. And then going forward, normally we will do MRIs on an annual basis. And the reason for that is to monitor disease activity that can be clinically silent. So one of the things we've learned from long studies looking at people who are living with MS and doing MRIs just on a periodic basis is that those lesions can appear even though you feel clinically normal. So you're not having any symptoms, nothing's going on, but the disease is active. And this is actually one of the biggest insights in MS disease activity that allowed us to use MRI as an outcome measure rather than waiting for a clinical symptom. So it turns out that those lesions are appearing about 7 to 10 times more frequently than you'll have a clinical event. And so the MRI is actually more sensitive than the clinical activity. So we like to do those at least annually for monitoring of disease activity. And what I like to say in this era where we have all these wonderful therapies, that we're aiming for two things. We're aiming for clinical silence, so no new activity clinically, but also radiographic silence. We want to see nothing new happening on those MRIs. So normally if we have a good baseline scan and there aren't too many lesions, we'll do an annual MRI without contrast. But in the setting of a new symptom, and we were talking about someone coming in and having new symptoms, you're trying to figure out, is this a new inflammatory event, or is this just a recrudescence of old symptoms in the setting of either fatigue or an infection? And then the contrast can be very helpful, because we know if you're having a new event that the contrast should be leaking out in this acutely inflamed area. So I hope that answered the question. Thanks.
Thanks, Dr. Sykott. There was a question that I want to read to the group, but because it's short. Are there any CRISPR study being done for MS? And Dr. Hafler answered experimentally all the time, clinically, not that I know of. Next question I have is, one son just stopped smoking as of last month. He stopped vaping, which he said was incredibly hard. very hard that my son has never smoked. So I assume that somebody in the family has MS. Maybe I missed parts of the question. So anybody wants to answer about smoking and MS? Dr.
I think that
Yada
question
or
had been
Dr.
directed
Murray?
to me. Yeah,
Okay, so go ahead.
it was the two-part question, and the question was really about whether the children of people living with MS, for example, should take vitamin D supplements. And I think that's a really difficult question to answer since, you know, although for most people taking vitamin D is probably quite safe, it's not true for everyone. So there are recommended daily allowances for children in general for taking vitamin D, but I otherwise usually suggest that that patients check with their pediatricians, with their kids' pediatricians, to see if there are any contraindications and what doses they would recommend. I think also, since we know that late adolescent obesity in particular appears to be an MS risk factor, as well as cigarette smoking, those are two other really great areas to work on as a family to sort of prevent obesity and make sure that we don't, you know, expose children to secondhand smoke, but also to make sure they don't become smokers. And I always like to tell people, since we know that improving the health of their diet and exercise and sleep probably relate to how they're going to do themselves with MS, but also might prevent MS in their offspring. It's kind of a nice family thing. You can all rally around it together to sort of treat everybody concomitantly with these healthy lifestyle factors.
Can I just make one comment about smoking and genetics, which I find absolutely fascinating? There's a wonderful paper by Lisa Barcelos at Berkeley, looking at smoking and genetics of MS. And she found that there's a particular genetic risk factor, a variant of a gene, that one. If you have that genetic variant, which is a risk factor for MS, and smoke, you have a markedly five-fold increased risk of developing MS. If you don't have that risk variant, then smoking is not a risk factor. And I think it's important in terms of understanding the underlying cause of MS, the complexity, and something Ellen studied very deeply with vitamin D. It's the combination of genetics and environment. So a particular risk factor for one individual based on the genetics may not be for another individual.
Thank you, Dr. Heffler. So 2 or 3 questions left. So first, before we continue with the last few questions, there's been several comments in the chat about how incredible the presentation and leaving so much time for question is. So thank you to the panel and Nancy for organizing this. How effective is IVIG for MS? I think there's a short answer to that. The trials that have looked at prevention of flares have showed only a very modest effect on preventing new scars on the brain MRI, but no effect in preventing flares. So we don't typically use those. There's been other trials looking at whether IVIG would help the repair, for example, of optic neuritis or an MS flare. And there's been really no evidence that it was helping the recovery. Anybody in the panel wants to add anything to that? Okay, good. So next question is that I have 5 siblings, 3 of us have MS, the other sister has Hashimoto, brother Raynaud, my aunt has several autoimmune issues, my niece is now showing signs of lupus and tested positive for it. Should she be tested for MS? She's 16-year-old and she's very anxious.
I would just, yes. Well, this is the one with lupus or is normal? Wasn't quite clear.
So the statement is that the niece is showing signs of lupus and has tested positive for it, or perhaps rheumatoid arthritis.
So should she have an MRI? Probably. And you wouldn't want to do it unless there's a potential therapeutic intervention. But these new clinical trials, which are emerging throughout the US, involve screening individuals at risk for MS. And that would be a very high genetic load. And if there were lesions on MRI, that would be, you do a spinal tap, and one might intervene therapeutically. So I would argue, yes, I think that's where we need to be moving in the field. And in fact, I'll throw out a crazy idea, see what even see what my former mentor thinks. So there's a MRI that's being manufactured down the street from my house in Guilford, Connecticut, by Jonathan Rothberg. It's called a Hyperfine. And when rather than going high field, with really strong magnets, Jonathan went very low field. And the magnet strength is low, but uses computational tools. And yesterday I just saw some MRI images of MS patients with T2 DWI imaging, are just spectacular. Machine cost about $30,000 wholesale. I'm not sure what retail is. And we're thinking of just screening everyone, for example, at Yale, to look for potentially early MS. So, the idea is that we can identify the disease really early and maybe do 1 or 2 treatments of B-cell therapy. Maybe that will be all that we need to do. But if you can bring the cost of an MRI down to a few bucks, takes 8 minutes to do, and a high school kid can operate the machine, maybe we rethink about how we screen populations. So I would have to do an MRI.
So David, very interesting. What you say has validity to it. In most of the diseases, the earlier you treat and the earlier you can identify, the better off we're going to be. I mean, that's how we treat heart disease and stroke, by screening blood pressure and cholesterol. I mean, Alzheimer's, that we don't have any drugs for yet. There's some blood tests that could be done. So if there's a simple test that could be done to screen the population for MS by an MRI, then I say yes. And then you could pick it up as early as possible, and you'd help people.
One thing which I would also say is, in a person who has a family member with multiple autoimmune disease, seeing a rheumatologist and getting the right diagnosis is really critical. The reason that is, if you, in an MS patient, there are certain drugs which should not be given, which can be given to, or which, for example, like are given to patients with, say, rheumatoid arthritis, so they can actually harm patients with MS. So accurate diagnosis is really critical. I would say see the experts and get the proper diagnosis, and then go through that route. If they feel that there is CNS involvement of any suspicion, definitely go for MRI and go from there. So I think the right diagnosis is the key here.
So the other thing that I would say, and David and everybody, your comments, is there a blood test we could do? Because a blood test is better than an MRI. So is there any type of blood test that we could develop? Because it's very easy to take blood samples from people. The military takes blood samples. You could say everybody should have a blood sample. I know there's debate about PSA testing and everything. What theoretically could be a blood test or something in the blood that might give a clue to MS early?
So Howard, I'm going to push back a little bit about the idea that the blood test is better than the MRI. I think what we can imagine is that in combination, if we have good markers on each side, that the two, putting them together will give you a much greater diagnostic certainty. In terms of what those markers are, I think Dr. Hafler probably has an opinion about that. Certainly looking at markers of myelin or axonal breakdown, neurofilament light, and certain other markers that have been shown. I think the combinations of those things could be helpful, but we also have to recognize that they are non-specific along with those white matter changes. And then finally, I want to hear more about this low field scanner, Dr. Hafler. Is it a 0.5 Tesla?
Oh, I just say that Jonathan Rothberg is the one who discovered high throughput sequencing, and he has a 180-foot yacht out in our backyard called Gene Machine. So Jonathan's been a creative force in nature. I don't remember, Nancy. It's probably less than 0.5. It's all computational, but it's just amazing. So let me, if I may not disagree with you, but make a slightly different point. So in terms of a blood test, what works in lupus and the military studies, Howard's referring to, measure autoantibodies against which occur in lupus and in rheumatoid arthritis. One of the big obstacles in MS has been our inability to find an autoantigen by antibody assays. And God knows we and everyone has tried all kinds of technologies. We've not been able to develop an early autoantibody against the disease, and maybe we need to look earlier. So that would be the best thing, an antibody, because those are easy to measure. The blood test I would do, and we plan on doing in our study, is look at T cell reactivity to brain antigens. And there are a number of tools, you and I developed these things back in the 1980s, and we refined these assays. So if MS is an autoimmune disease, and if T cells are attacking the brain, then the earliest event ought to be a high frequency of these T cells in the circulation. And that's what we're doing. But Nancy, to get to your point, absolutely. Once you have parenchymal disease, I think the MRI is really critical. However, what I'd like to do is push the paradigm back and look at type 1 diabetes in the animal model. That before you have tissue invasion into the islet cells with destruction, you have inflammation around the islets, a perianthelitis. It's beautiful work going back 10 years by Federica Sallusto in the EAE model, the animal model. That's where I think it's useful. And she showed before you have invasion of the brain, there's inflammation around the brain. So what we want to explore is, can we identify, and we came up with the name, not radiologic isolated syndrome, where you have MS and there's parenchymal damage, but can we identify the syndrome before there's damage, where there's a perimeningeal disease, where there'll be inflammation in the spinal fluid. So we plan on taking individuals at risk for MS with high genetic load, and to do spinal taps. We now routinely do spinal taps on all our medical school and grad students for normal studies. And so we lowered our threshold to see if we do enough spinal taps or new imaging techniques with nuclear medicine. Can we image the inflammation around the brain as a first event? And their MRI may not be useful. So I totally agree with you, but I want to push the paradigm back even more.
So David, I was with Henry McFarland years ago, many years ago.
I was with Henry before you were with Henry.
Yeah, I know. So everybody's been with, and Nancy Davis has been with Henry, everybody's been with Henry. But my point is that, and Steve Hauser's done some of this too. So I actually studied multiplex families where we had identical twins, some had MS, some didn't. We had how it is, right? We've all done this. And so what do you see that we missed? Because, so many people, and I did it myself with my own hands, honest to God, all these myelin proteins and trying, and there are papers, and, you had very good papers, and Roland Martin and Henry and, and Howard. But what do you think is new now that we've studied families, and those families are at risk because we've seen identical twins who don't, et cetera. So my question to you, and you'd be the one to do it, would be, what would be different in looking for this antigen that we've all done so much, even on these multiplex families in the past?
Well, I think there is increased reactivity with different assays to myelin antigens in MS patients. We showed years and decades ago that we all have immune cells reacting to brain, but what's different is in MS, those autoreactive T cells are inflamed, where in healthy individuals, they are anti-inflammatory. So we have new tools for looking at it, but I think the answer is in the spinal fluid, that we need using class 2, and we're just getting very, I hope the group, we're having a scientific discussion.
Yeah, maybe we should have the scientific discussion after the panel is over, because we're losing some of our audience here in
yeah, but that's trying to keep it simple, but I think, Rhonda, there are techniques, if we look in spinal fluid, maybe ways of identifying it.
So there are 2 more questions before we conclude this panel discussion. The first one, maybe Dr. Yadav or Dr. Maury can answer. Are there any vitamins you recommend taking for MS?
I would just say, I think vitamin D, definitely we should check and make sure they are, the levels that we are recommending right now is between 40 and 60, which is nanogram per ml. So at least that's one vitamin that I can think of. Besides that, a daily multivitamin may be just good for general health, but beyond that, there's no other specific vitamin that we are recommending. Many people take like B12, specifically for fatigue, but frankly, if you look at the studies of B12 in MS, there was no conclusive evidence to really use that. But some people, especially naturopath, the naturopathic physician, they sometimes would prescribe B12 for fatigue, but that's not really a proven therapy for MS. So I think that's pretty much, I would say.
Dr. Maury, anything you want to add before we take the next question, the last question?
I usually ask people to focus on the health content of their foods rather than taking extra vitamins. So I think, again, increasing data suggesting that avoiding cardiometabolic problems like diabetes and high blood pressure are really important for long-term health in people with MS. How do we avoid those conditions? We have a healthy diet, among other things. And so that, may include some variation on the Mediterranean diet. Lots of studies trying to look at, is there some specific MS diet? But, being sensible, eating plenty of vegetables and fruits, eating some fish at least once a week, I recommend to patients, reducing red meat. And, I think avoiding things that come in packages, and it's not like you have to be a saint about this, but I think we're too reliant on processed foods. And if you consume those other foods and, for the majority of your intake, you'll get the nutrition you need unless you have some sort of gut disorder that means you're not, absorbing that nutrition. So I think, rather than focusing on yet another pill, try to work on the quality of the diet itself.
Same for probiotics, right?
Mm-hmm.
Yeah, right now I don't feel that I have a way to recommend a given probiotic for people, rather to focus on the foods that they're eating as, things that if we're eating what we're supposed to, what we've evolved to eat, you should be supporting the health of the right kinds of bacteria in the gut.
Yeah, and I think the evidence for probiotic is mostly for patients who have recurrent UTIs. And so in that context, urologists will recommend probiotics, but otherwise there's really no evidence. So I think we're going to take the last question, which of all the questions, I think may be the most challenging for the panel, I would expect. A question to all doctors on the panel: if you could only choose one disease-modifying therapy, which would it be and why? So remember, lightning round, short answer.
So I'll start. If I only had one to choose, I would choose anti-B cell therapy for relapsing MS, I assume.
I agree. I would choose anti-B cell therapy.
If I were JC negative, I would do natalizumab. If I were positive, I would do a B cell depleter.
I totally agree with Nancy. And David and Howard.
Anybody wants to continue answering, and then I'll answer?
I'm running a trial to evaluate this, so I think I'm not certain. We're trying to look at whether using these strong medications actually makes a difference, and if it's true for everybody, or if some people can get away with milder therapies. So.
Right, and like David said earlier, not forever. Just to get things chilled out, right?
Though, Ellen, I'm going to push back and say you're saying stronger therapies. I'm not sure B cell depletion is really that much stronger than giving shots of interferon every few days.
So the panel members are talking about B cell therapy, which is the rituximab, ocrelizumab, Kesimpta. So on my end, I think it's really actually a very complex question to answer, because it really depends whether early on, so first, when you start treatment, if you're early in the disease process or later, whether you have a progressive form or a relapsing remitting form, whether some of the blood markers put you at risk of specific complications with some of the medications, and then also to to make sure that I would take the medication regularly so I would not forget. Or so I think it's a very complicated questions. And in addition, you add the layer of what insurance will cover and will be your copay, and then that's the last nail in the coffin.
Manuel, my answer, I agree with you.
Okay, anybody else wants to chime in for that last question? Otherwise,
I just want to say it depends on the question, what they're saying. So the question really is, if you are on a desert island somewhere, or you only had one drug, you were taking care of MS patients and you only had one drug to use, no other drugs, one drug, and that's the only drug you had for MS, which one would you choose? I think that's the question. Your answer, Emmanuel, is the right answer, that it depends on the patient and when and how and everything. That's the right answer. If you want to play games and say you only have one drug on Mars or something and there's MS, then I would say you take a B-cell therapy, but that's not what we should do on Earth.
No, MS is a spectrum, so I'm not sure there's one drug for every patient. So I think it is very individualized, personalized approach that we have to follow.
And so we're going to close this. And Claudia, do you want to end the session?
Yes.
Thank you, everybody, for participating.
Thank you, doctors and David and Nancy. I always learn so much from these forums. Thank you so much. And I'm going to turn it over to Nancy to conclude our session.
Okay, it was so fascinating today to listen to everybody, and why we have a center without walls is because all of you communicating and talking to each other. So much more happens than everybody working in an isolated way. When I started this so many years ago, it was fascinating to me that there wasn't this communication, but when you put the best and the brightest minds in our country together to work as a team like you do, this is what happens. And I'm just amazing to listen to. I learn something new every single time I talk to you all. And I'm so excited to ask more questions later on, but I won't do that right now. Thank you for what you're doing. I thought, and when you're talking about B-cell depletion, I think everyone should know that means Ocrevus, possibly Rituxan. I know you guys are very smart and say it in a different way, but that's what it is. And it's so grateful that you guys all come together, and there's so much that can happen this way. And I know this is not very typical in most other diseases other than our disease, and I congratulate all of you. You're so smart, you're brilliant, you bring so much to the table. Because of you, we are where we are today. We would not be here if it wasn't for each one of you participating and communicating what you do. And I think it's so fascinating, and we're just going at a huge pace. So thank you a million times for everything you all do.
And remember, you can tell people to watch the recording.
Yes, everybody should watch this, and they can go on our website for Race to Race MS, and it will be there forever. They can keep looking at it. I think it's very informative, and as people go on with their MS, there's different symptoms that come up, and there's different things that are happening. And it's nice to sort of refer back to this and look at what that is. And there's different things that happen when you have different MS attacks, and you go through different peaks and valleys in your MS. And it's nice to be able to look back at this and listen to everything. But everything everybody said is so interesting and amazing. So thank you all at least a gazillion times, and what you're doing is beyond brilliant and beyond helpful for everybody. So I don't even know how to say thank you again, but you're amazing, all of you.
Thank you, Claudia and Nancy.
Thanks, Nancy. Thanks, Claudia. Good to see everybody.
Claudia and Liz and Nancy.
Absolutely, Liz.
David too. Thank you so much,
David.
Your perspective on living with MS and what you've done is amazing as well.
Bye-bye.
Right,
Thanks, everybody. God bless.
Bye, everyone.
Bye, everybody.
Take care.
Good weekend.